Good morning, dear students. My name is Oksana Matsura. I am Associate Professor of the Department of Pediatrics number 2. Today we have speak with you about rickets and hypervitaminosis D. Our lecture plan is to discuss an impact of vitamin D, calcium, and phosphorus on health, growth, and development of children. In details, we will speak about definition, etiology, pathogenesis, classification forms, causes of the disease, diagnostic strategy, treatment, prognosis, and clinical cases of rickets and hypervitaminosis D. So we will start from first question about importance of vitamin D, calcium, and phosphorus for children. Centuries ago, during the Industrial Revolution, rickets, also called the English disease, spread rapidly among city-dwelling poor children and became endemic due to vitamin D deficiency and insufficient access to sunlight. Nowadays, it appears to be endemic again as the increase of vitamin D deficiency is paralleling the primacy of breastfeeding in Western societies. Breastfeeding, nutritional status, and dark skin are the main risk factors for rickets. Rickets is a childhood disorder, and the basis for understanding the disease is rooted in the concept of mineral metabolism and its control mechanism in the growing fetus, infant, and child. As it now understood that rickets is not only caused by vitamin D deficiency, it has to be kept in mind that vitamin D and calcium deficiency is prevalent in developing countries as well as in affluent societies where children and their mothers are not exposed to as much sunlight as they need. The rapid growth in molecular biology has been exemplified in the application of subcellular technologies to study vitamin D in the human and animal models. The latest research on vitamin D and rickets is presented from different perspectives, such as the interesting historical overview to bone metabolism, molecular genetics of vitamin D, and conclusions for disease prevention. It will be of special interest for pediatrics, endocrinologists, and healthcare specialists who work with children at risk for this disease. What we know about the history of name rickets? The name rickets is from the Old English ricken, to twist. The more technical medical term, rickeitis, which comes from Greek, the spine, was suggested by Francis Gleason that both from similarity of sound and from the part of the body which he thought was one of the first to be affected. Nowadays, there are many discussions about vitamin D and question, is vitamin D a hormone? Vitamin D is not a vitamin in the strict definition because it can be produced by exposure of the skin to sunlight. As such, animals and humans don't have a dietary requirement for vitamin D when sufficient sunlight is available. Nutritional vitamin D becomes essential when sunlight is insufficient to meet daily needs. This has become particularly acute as more people reside in urban centers when they are exposed to suboptimal levels of sunlight. Air pollution, clothes, tall buildings, indoor dwelling, and another ultraviolets from the sun, and these factors all reduce the ability of the skin to synthesize vitamin D3. People living far north or south of the equator obtain little ultraviolet radiation during the winter months. The same is true for Middle Eastern women who remain indoors or cover their entire body from sunlight. Under these conditions, vitamin D and its hormone derivative calcitriol can be considered a bona fide vitamin in that it must be supplied in the diet. It is very important to know units of vitamin D. The World Health Organization has defined the international unit of vitamin D3 as the activity of 0.025 gram of the international standard preparation of crystalline vitamin D3. One international unit of vitamin D3 is 0.025 gram or 65 mol. The unit definition of the active metabolite calcitriol was said to be equivalent in molar terms to that of the parent vitamin D3. One unit is 65 pmol of calcitriol. As such, the unit of calcitriol is much more active than the unit of vitamin D itself. The vitamin D requirements for children or adults have not been precisely defined. Historically, it was defined on the basis of vitamin D content in a teaspoon of fish oil, a quantity shown to be sufficient to prevent rickets. So vitamin D is a fat-soluble vitamin and its sources can be present in foods but naturally found in very few foods, added to many foods on the market, can be in supplements and sunlight. Vitamin D plays a very important role in many uses in the body. It promotes absorption of calcium from the small intestine, maintain blood levels of calcium and phosphate for bone formation, mineralization, growth and repair, improves muscle strength and immune function, and reduces inflammation. On this picture, you see that vitamin D2, ergocalciferol, and vitamin D cholecalciferol are biologically inert and require two separate hydrolyzations to give rise to active form. There are active and inactive forms of vitamin D. 1.25 dehydroxyvitamin D is physiologically active form and his serum half-life has 4 to 6 hours. The inactive 25-hydroxyvitamin D3 most often measured clinically in the serum and its indicator of vitamin D stores in the body reflects amount of vitamin D derived from both food and sun and has 2 to 3 weeks half-life. When to speak about pathogenesis of rickets, it's a failure of growing bone to mineralize. Many skeletal and radiographic changes can occur because of the lack of calcified osteoid and the buildup of anossified cartilage. Proper bone formation requires a complex interplay of several organs and chemicals, and vitamin D deserves special mention because any disturbance in its production, absorption, or metabolism is paramount in the development of rickets. Human beings maintain adequate level of vitamin D by producing it from cholesterol or by absorbing it from ingested food sources. Sunlight is a vital component necessary for production of vitamin D, which begins in the skin and ends in the kidney. At risk of vitamin D deficiency are breastfeeding infants, people with limited sun exposure, and darker skin pigments. Vitamin D has many functions, and one of the main roles is calcium and phosphorus homeostasis, calcium and phosphorus absorption, which takes place in small intestine, calcium resorption in bone and kidney, and maintain blood calcium levels. Also very important is bone formation, stimulate calcium uptake for desorption as calcium phosphate, and hormone regulation of gene expression and cell growth. Vitamin D plays a role in regulation of calcium metabolism. When we speak about minerals, it's very important to know serum concentration. And please remember that normal levels for calcium in serum is 2.2 to 2.6 millimole. Phosphate 0.7 to 1.4 millimole, and magnesium 0.8 to 1.2 millimole. Organ systems that play an important role in calcium metabolism are skeleton, gastrointestinal tract, and kidney. And calcitropic hormones are parathyroid hormone, calcitonin, vitamin D, and parathyroid hormone related protein. It is very important to speak about calcium balance, so equal doses of intake and output. Negative calcium balance is in osteoporosis cases when output is higher than intake. In the same way, positive calcium balance when intake doses are higher than output, and it can be present during first 3 years of patient's life and puberty. Calcium is essential. We cannot synthesize it. There are three forms of circulating calcium. 50% is ionized, free, biologically active form. About 40% is protein-bound, non-diffusible, biologically inactive. And 10% complexed with phosphate, bicarbonate, and citrate. Please pay attention that total level of calcium is 2.2 to 2.6 millimole per liter. In this form, ionized calcium has about 1.1 to 1.3 millimole per liter. Protein-bound calcium 0.9 to 1 millimole per liter, and complex calcium forms 0.2 to 0.3 millimole per liter. Calcium metabolism plays a role in bone. Main effect is stimulates osteoclasts, bone breaks down, and calcium is released. Intestines increases uptake of calcium from intestine, and kidney stimulates reabsorption of calcium from the calcium in kidney tubules. On this picture, you can see calcium metabolism. Osteomalacia, the bone disease in rickets, results from a defect in the mineralization of bone matrix with increased bone mass. It is to be distinguished from osteoporosis, where bone mass is decreased, from hypophosphatemic osteopenia of premature infants, and from renal osteodystrophy, which is partly due to calcitriol renal deficiency, but also due to hyperphosphatemic hyperparathyroidism. When osteomalacia wrecks the growth plate of a growing child, it impairs longitudinal bone growth, producing widening and disorganization of its structure. These result from extensive compensatory proliferation of growth plate cartilage cells, mostly in the periphery of the plate, to give the cup-shaped metaphysis, whereas cartilage mineralization is excessively, showing as a white hazy layer on the top of the metaphysis. The latter exhibits insufficient mineralization, and this type of epiphyseal dysplasia is defined as rickets. Causes of calcium deficiency are low calcium intake in diet, vitamin D deficiency, insufficiency or failure of parathyroid gland, chronic kidney failure, and low blood magnesium level. In this case, it's very important to know about sources of calcium in the diet. They recommend patients and their children to take milk, yogurt, cheese, and dark green vegetable. Also, we have fortified sources which are present in cereals, bread, and orange juice. Phosphorus plays an important role in cellular metabolism. It's a source of energy in cellular reactions and component of phospholipids in membranes. Here you can see maintenance of calcium and phosphate homeostasis, and it depends on intestinal, bone, and renal function. Calcitonin is synthesized by parafollicular cells of thyroid gland. It affects the metabolism of calcium and phosphorus and promotes the transferring of calcium from blood into bones and inhibits reabsorption of phosphorus in kidney that decreases the content of phosphorus in blood due to its excretion with urine. Increase of calcitonin develop hypocalcemia, hypophosphatemia, and hyperphosphaturia, and decrease of calcitonin develop hypercalcemia, hyperphosphatemia, and hypophosphaturia. Main regulators of calcium and phosphorus is parathyroid hormone. It's a fat-soluble steroid that is present in the diet and can be sensitized from the skin. Phosphorus take part in the formation of bones and teeth. It's a part of high-energy phosphate compounds, constituent of DNA and RNA, most abundant anion present in tissue cells, and forms esters with sugars. So when we speak about the rickets, we have to summarize our knowledge and diagnostic in case of minerals such as calcium, phosphorus, and vitamin D concentration. Now we will speak with you about main clinical features of rickets. Key point is that predominant cause of rickets is nutritional deficiency of vitamin D due either to inadequate direct exposure to ultraviolet rays in sunlight or to inadequate intake of vitamin D or both. Vitamin D deficiency rickets has been almost eliminated among infants and children in the industrialized countries by prophylactic means. Deficiency may occur in unsupplemented dark-skinned infants or in breastfed infants of mother unexposed to sunlight. Rickets is a polydeficit disease with a disruption of the metabolism, especially calcium phosphorus minerals exchange. This is a multi-organ disruption disease and of the gross bone tissue. Rickets is the most common in infants. It leads to high morbidity, increased immunodeficiency of constitution, delaying infants' physical and neuropsychological development. There are greater incidence of respiratory disease, interruption in cardiovascular system, variety of bone deformation in children with rickets. Therefore, prevention and treatment of rickets occupy a leading position in the child has complex arrangements and reduce infant mortality and child morbidity. What is definition? Rickets is a disease of young children which occurs because of deficiency or disturbed metabolism of vitamin D. It is accompanied by disturbed phosphor-calcium metabolism and manifests clinically through bone tissue lesions in the form of osteomalacia, hyperplasia of the osteoid tissue, disturbed endochondral ossification, lesions of the muscular system, and internal organs. On this picture, you see a patient with symptoms of rickets, and pathognomonic will be large heart, protruding forehead, protruding abdomen, pigeon chest, depressed ribs, enlarged epiphysis at wrist, enlarged epiphysis at ankle, cured tibia and fibula, cured femur, and kyphosis. As we spoke with you before, risk factors for rickets are dark skin. Dark skin has more of pigment melanin, which lowers the skin ability to produce vitamin D from sunlight. Its mother vitamin D deficiency during pregnancy. A baby born to a mother with severe vitamin D deficiency can be born with signs of rickets or develop them within a few months after birth. Northern latitudes, children who live in geographical locations where there is less sunshine are at high risk of rickets. Premature birth, baby born before their due dates, can have lower levels of vitamin D because they had less time to receive the vitamin from their mothers in the womb. Taking of medications and certain types of anti-seizures medications and antiretroviral medications also used to treat HIV infections appear to interfere with the body's ability to use vitamin D. And exclusively breastfeeding children because breast milk doesn't contain enough vitamin D to prevent rickets, and babies who are exclusively breastfed should receive vitamin D in drops. Here you can see plan of examination of patient who potentially can develop rickets. You have to observe head phoboses and flattening, to palpate anterior and posterior frontalis, to check bones for rigidity, observe the child standing upright with feet together, inspect the spine for curvatures, inspect the teeth for eruption, and inspect ribs for horizon groove. On this picture, you can see bowing versus knock knee, which can be present during severe form of rickets. During severe cause of rickets can be present also changes on the hands, and you can see here enlarged epiphysis at wrist, horizon groove, and also protruding abdomen. On this picture, you see radiographic image showing typical changes of rickets. The distal ends of the radius and ulna display extensive cupping, fraying, and splaying of the diaphysis with widening of the metaphysis. Here you can see enlarged epiphysis at wrist and odd-shaped legs with wide bones and curved femur. Clinically, there are two main types of rickets. They are calcipenic rickets and phosphopenic rickets. When we speak about calcipenic rickets, it's nutritional vitamin D deficiency of calcium deficiency rickets, or hereditary, when vitamin D dependent rickets has two types. Type 1, also called pseudovitamin D deficiency ricket, when vitamin D has defect of metabolism, or type 2, also called vitamin D resistant rickets, because end organ resistance to vitamin D. Phosphopenic rickets are also nutritional and hereditary. Nutritional means phosphate deficiency rickets, and hereditary are in other forms. X-linked hypophosphatemic rickets, autosomal dominant hypophosphatemic rickets, autosomal recessive hypophosphatemic rickets type 1, and autosomal recessive hypophosphatemic rickets type 2. Also is present hypophosphatemic rickets with hypercalciuria and syndrome associated rickets. Nutritional rickets are globally nutritional deficiency are the leading cause of rickets. Infants fed exclusively with mother's milk can develop nutritional rickets because of the low concentration of vitamin D in breast milk, about 30 to 40 international units per liter. In premature infants, insufficient amount of both calcium and phosphorus may cause nutritional rickets, and infants with low or no sun exposure may develop rickets, particularly if they have dark skin because of decreased vitamin D production by the skin after exposure of ultraviolet light. Hereditary rickets. Onset of this type as usually happens in the first 6 months of patient's life. It's quite rare in industrialized countries, however, it's common in developing countries. It occurs when there is maternal vitamin D deficiency during pregnancy As well, maternal risk factors include poor dietary intake of vitamin D, lack of adequate sun exposure, and closely spaced pregnancies. These newborns may have symptomatic hypocalcemia, intrauterine growth retardation, and decreased bone ossification, along with classic Rickets changes. Subtle maternal vitamin D deficiency may have an adverse effect on neonatal bone density and birth weight. It can also cause a defect in dental enamel and predispose infants to neonatal hypocalcemic tetany. Use of prenatal vitamins containing vitamin D prevents this entity as well prophylactic vitamin D supplementation from base dose of 500 to 1000 units per day will prevent this entity. Vitamin D dependent rickets occurs because of a defect in one alpha hydroxylase enzyme, which is responsible for the conversion of 25 hydroxycalciferol vitamin D into the active metabolite. Type 2 vitamin D dependent rickets occurs due to end organ resistance to calcitriol, which is very rare autosomal recessive disorder, which is usually caused by mutations in the gene encoding for vitamin D receptors. This disorder results from a genetic deficiency in one alpha hydroxylase enzyme that converts calcidiol to calcitriol in the kidney. It is inherited as an autosomal recessive, and the gene is located in band 12q13.3. Clinical and laboratory examination findings are similar to those associated with nutritional rickets, with low levels of 1.25 hydroxycalciferol vitamin D, with normal values of 25 hydroxyl vitamin D3. These patients develop rickets despite receiving vitamin D at the recommended preventive doses. Medical treatment consists of oral calcitriol 0.5 to 1.5 microgram per day or 1 alpha dose 1 microgram per day. This patient may also respond to suprapharmacologic doses of vitamin D from 5,000 to 10,000 units per day. Vitamin D resistant rickets or type 2 vitamin D dependent rickets is a rare autosomal recessive disorder most often caused by mutations in the vitamin D receptor gene. It is usually present with rachitic changes not responsible to vitamin D treatment, and the circulating levels of both 25 hydroxycalciferol vitamin D3 and 1.25 hydroxylase vitamin D3 are elevated, differentiating him from vitamin D dependent rickets type 1. Alopecia capis or alopecia totalis is seen in some families with vitamin D dependent rickets type 2. It is important to remember that it is usually associated with a more severe phenotype. The clinical picture is evident early in life and consists of rickets with very severe hypocalcemia, also as a variant without alopecia has been reported. Patients without alopecia appear to respond better to treatment with vitamin D metabolites. Serum levels of 1.25
hydroxycalciferol vitamin D3 are typically elevated. It can be lethal in the perinatal period, and several mutant forms of receptor defects are recognized in rickets, with a wide range of severity and response to calcitriol therapy. Patients are benefiting from continuous intravenous calcium through central line or with high doses of calcium to prevent secondary risk of nephrocalcinosis, hypercalciuria, nephrolithiasis, and cardiac arrhythmias. On this picture, you can see a patient with vitamin D resistant rickets, and you can find their changes, ricket changes, and alopecia. Hypophosphatemic rickets is less common than hypocalcemic rickets. Also, pediatricians should be aware of its occurrences, characterized by rickets associated with hypophosphatemia resulting from dietary phosphorus deficiency or due to defects in renal tubular function. Skeletal deformations are present, but hypoxemia, myopathy, and tetany are absent, and serum parathyroid hormone will be normal. Hypophosphatemic rickets can develop due to poor dietary intake, malabsorption diseases, prematurity, renal phosphate wasting, hereditary hypophosphatemic rickets, renal tubular acidosis, or oncogenic hypophosphatemia. So, what we know about hypophosphatemic rickets? Several different familiar and acquired conditions may lead to hypophosphatemia in children. Kidneys fail to reabsorb sufficient phosphate, leading to low levels of serum phosphate. This is usually evident only after age 6 to 10 months. Prior to this occurrence, the glomerular filtration rate is low, which sustains an adequate phosphate level. Once renal maturity is reached, phosphate levels are usually low. Levels of 1.25 hydroxycalciferol vitamin D are normal in these patients, which is actually an abnormal response to hypophosphatemia, in which levels of 1.25 hydroxylase vitamin D should be increased. Mutation of phosphate regulating gene with homologous to endopeptidases on the X chromosome and dentin matrix protein 1 results in X-linked hypophosphatemic rickets and autosomal recessive hypophosphatemic rickets, respectively. Most families of patients with familiar hypophosphatemia exhibit an X-linked dominant inheritance. Fibroblast growth factor 23 has been implicated in the renal phosphate wasting in tumor-induced osteomalacia and autosomal dominant phosphatemic rickets. Because calcium levels remain normal, neither tetany nor secondary hyperparathyroidism are present. Renal osteodystrophy or renal rickets is the end-stage renal disease. Renal 1-hydroxylase is diminished or lost, and excretion of phosphate is defective. This leads to low levels of 1.25 hydroxylase vitamin D, hypocalcemia, and failure of osteoid calcification. Osteodystrophy, renal rickets, is the one type of rickets with a high serum phosphate level. It can be dynamic or hyperdynamic. Treatment of these patients includes phosphate binders, a low phosphate intake, and calcitriol or 1-alpha vitamin D. As progressive renal disease is associated with a decline in serum calcium resulting from several factors. Important among these are a rise in serum phosphate as the ability of the kidney to clear absorbed phosphate declines and a fall in serum levels of 1.25 hydroxylase vitamin D because of diminishing renal production of this metabolite. The consequent stimulation of parathyroid function can lead to severe secondary and even tertiary hyperparathyroidism, and therefore early intervention with phosphate binders and 1-alpha or calcitriol analogs are recommended. Fanconi's syndrome. It is a disease of the proximal renal tubes of the kidney in which glucose, amino acids, uric acid, phosphate, and bicarbonate are passed into the urine instead of being reabsorbed. It may be inherited or caused by drugs or heavy metals. The loss of bicarbonate results in type 2 or proximal renal tubular acidosis. The loss of phosphate results in the bone disease rickets, even with adequate vitamin D and calcium. The clinical features of proximal renal tubular acidosis include polyuria, polydipsia, and dehydration, hypophosphatemic rickets, growth failure, acidosis, hypokalemia, hyperchloremia, hypophosphatemia, phosphouria, glucoseuria, and proteinuria. Hepatic rickets. Vitamin D is hydroxylated in the liver to form 25-hydroxyvitamin D, and patients with severe parenchymal or obstructive hepatic disease may have reduced production of this metabolite. These patients rarely manifest biochemical or histological evidence of rickets. Indeed, an overt decrease of 25-hydroxyvitamin D generally requires concomitant nutritional deficiency or interruption of the enterohepatic circulation. Often are asked questions about rickets and osteomalacia. Rickets is a disease of the growing bones in which defect mineralization occurs in both bone and cartilage of the epiphyseal growth plates. It is associated with growth retardation and skeletal deformation. Osteomalacia is a disorder of the mature bone in which mineralization of new osteoid bone is inadequate or delayed. Skeletal muscles have a vitamin D receptor and may require vitamin D for maximum function. Vitamin D deficiency causes muscle weakness. Brain, parathyroid glands, breast, and colon tissues, among others, as well as immune cells, have vitamin D receptors and respond to 1.25 hydroxyvitamin D. And another type is oncogenic osteomalacia. It is paraneoplastic syndrome with hypophosphatemia secondary to decreased renal phosphate reabsorption, normal or low serum 1.25 dehydroxyvitamin D concentration, and osteomalacia. Several tumors of bones or connective tissue can result in rickets, and the age of the onset has been late childhood, adolescent, or even young adulthood. The clinical characteristics are similar to those associated with familiar hypophosphatemia. Treatment is surgically removing of the tumor with excellent results.
On this picture, you can see classification of rickets. So it's classified into disease progress, severity degree, clinical variants, and disease periods. When we speak about disease progress, it can be acute, subacute, or recurrent. When we speak about severity of the degree, it can be mild or first stage, moderate, second stage, and severe, third stage. Clinical variants can be hypocalcemic, hypophosphatemic, without significant deviations of calcium and phosphor content in the blood. And disease periods are primary, eruptive phase, recovery, and residual effects. Severity mild is diagnosed in case of lesions of 1 to 2 skeleton sections. Moderate lesions of more than 2 skeleton sections and muscular hypotonia. And severe lesions of all skeleton sections, muscular hypotonia, and lesion of the internal organs. Clinical presentation. The primary period during the whole first year of life, but more often at 2-3 months, is manifested through excessive sweating, anxiety, muscular hypotonia, and insignificant softening of the edges of anterior fontanelle. The eruptive phase, the fourth 6 months of patient's life, is characterized by symptoms of nerve system suppression. The bones of the skull, chest, and extremities are deformed. Dysfunctions of the internal organs, impairment of static function, muscular hypotonia are detected. In laboratory signs is anemia, hypocalcemia, hypophosphatemia, and increased activity of alkaline phosphatase in the blood serum. The period of residual effect is the second, third year of life. There are consequences only in the form of bone deformations, and sometimes anemia is present. In children with rickets, complete physical and dental examinations should be performed. The entire skeletal system must be palpated to search for tenderness and bony abnormalities. Bow legs, in the absence of other findings, are relatively common in normal children in the first 2 years of life. Rickets should be suspected in older bow-legged children and in cases associated with asymmetry, pain, or progression in severity. Guide disturbances in the ambulatory child and neurologic abnormalities such as hyperreflexia in all children should be sought. In infants, clinical features of hypocalcemia include seizures, apnea, and tetany. In children, clinical features of rickets include delayed motor milestones, hypotonia, enlargement of wrists, progressive bowing of long bones, Rickets rosari, Harrison sulcus, and also delay in teeth eruption, enamel hypoplasia, and propensity for infections. In laboratory investigation, we need to control serum level of calcium, total and ionized, with serum albumin, phosphorus, alkaline phosphatase, parathyroid hormone, urea, nitrogen, creatinine, calcidiol. Urine studies include urinalysis and levels of urinary calcium and phosphorus, and the serum levels of calcidiol in inadequate of the patient's overall vitamin D status. Now we will speak about diagnosis of nutritional rickets. Early or initial stage in which there is osteopenia, hypocalcemia, or normal serum calcium concentration, hypophosphatemia or normal blood phosphorus concentration, an increase in serum alkaline phosphatase, which is very sensitive to rickets, and increase in parathyroid hormone concentration and a decrease of plasma 25 hydroxyvitamin D concentrations. Moderate or second stage, in which there are initial radiographic signs of rickets, such as bowing deformations of the legs and widening of the wrist, with concomitant hydration and swelling of the collagen matrix, expansion of the periostal covering, and bone pain. Also, hypocalcemia or normal serum calcium concentration due to bone calcium mobilization stimulated by the increase in parathyroid hormone, clear hypophosphatemia, and a moderate increase in alkaline phosphatase and parathyroid hormone, and a greater decrease in plasma 25 hydroxyvitamin D concentration. Severe or final stage, in which bone changes become more severe. Hypocalcemia is evident, hypophosphatemia is more severe, as well as the increase in alkaline phosphatase and parathyroid hormone, and there is a more severe decrease in plasma 25 hydroxycholecalciferol concentrations. Here you can see conditions that can cause rickets. In this content, you have to ask patients or his parents about medications taking, about antacids, anticonvulsants, corticosteroids drugs, loop diuretics, and malignancy. Also, premature babies, disease of organs associated with vitamin D and calcium metabolism, kidney disease, liver and biliary tract disease, malabsorption syndrome, celiac disease, or cystic fibrosis. What complications of rickets? They are failure to grow, abnormality cure spine, bone deformations, dental defects, and seizures. First question you have to discuss with patient is diet correction. And on this picture you can see calcium content of various food in milligram. And you see that breast milk, cow's milk, dairy products are rich with calcium, and it's the main source of calcium for young children. Prevention of rickets is to eat foods that contains vitamin D naturally, fatty fish such as salmon and tuna, fish oil and egg yolks. Foods that have been fortified with vitamin D such as interformula, cereal, bread, milk, yogurt, cheese, and orange juice. Most infant formulas contain at least 400 units per liter of vitamin D, so formula-fed infants will also require supplementation to meet this goal unless they consume at least 1 liter daily of formula milk. It's very important information for you to remember. Another strategy to raise vitamin D levels in exclusively breastfed infants is to administer high doses of vitamin D to the lactating mother. And this intervention sufficiently increases the vitamin D content of breast milk to allow sufficient vitamin D intake by the infant without causing hypervitaminosis D in the mother diet. Prescriptions of vitamin D for therapeutic purposes. In case of mild form, it's recommended 2,000 international units, moderate 4,000 international units, and severe 5,000 international units. And you have control patients' clinical symptoms and blood samples every 30 days in case you prescribe high dose of vitamin D. Treatment of rickets also includes non-specific recommendations. They are increasing exposure to sunlight, making dietary changes, taking fish oil, getting more exposure to ultraviolet light, and consuming calcium and phosphorus. In case of vitamin D dependent rickets type 2, the patient is recommended to continuous daily of calcium intravenous infusion in high oral dose of elemental calcium. Some reported cases as high as 14 to 20 grams per day, supplemented with oral phosphate is an effective method of treatment of vitamin D dependent rickets type 2. In this case, the treatment is more effective when it is started early in the course of the disease and lead to early healing and better growth with prevention of bone deformations. As well, early treatment may also lead to improvement in alopecia, the mechanism for which needs to be elucidated. In case of hypophosphatemic rickets, optimal therapy consists of oral phosphate in a dose of 40 to 60 mg per kilogram daily in 5 divided doses plus oral calcitriol. Calcitriol prevents increases in parathyroid hormone caused by phosphate therapy. So summarize the treatment of different form of rickets. We have to know that when patient develop first symptoms, you have to control him in dynamic and to increase the dose of vitamin D. And if patient need additional components, you have to follow up and to control. It's more easier to prevent the disease than treat the symptoms and then treat the complications. Please remember this information. Dear students, now I want to check your knowledge about today's our topic in practice questions. Calcium deposition in soft tissues is due to deficiency of vitamin D, excess of vitamin D, excess of vitamin K, and deficiency of vitamin C. So, what do you think about? The correct answer is excess of vitamin D, and we discuss this problem today in our lecture, that calcium can be deposited abnormally in soft tissue, causing it to harden. Classification of soft tissue can be caused by vitamin K2 deficiency or by poor calcium absorption due to a high calcium vitamin D ratio. This can occur with or without a mineral imbalance. Second question is about deficiency of calcium may lead to a condition called goiter, anemia, tetany, or scurvy. So, what is correct answer? It's tetany. It's a condition marked by intermittent muscular spasm caused by malfunction of the parathyroid glands and a consequent deficiency of calcium. Goiter is caused by thyroid dysfunction. Anemia is caused by iron deficiency, and scurvy is vitamin C deficiency disorder. Third practical question is about nutritional disorders associated with overnutrition except. And you have four options: hypervitaminosis, obesity, fluorosis, and osteomalacia. This question is easy if you was focused in today's our topic. Correct answer is osteomalacia. So it's a softening of the bones caused by impaired bone metabolism, primarily due to inadequate levels of available phosphate, calcium, and vitamin D, or because of resorption of calcium. Fluorosis is a cosmetic condition that affects the teeth. Obesity is a state of being grossly fat or overweight, and hypervitaminosis is a condition of abnormally high storage levels of vitamins, which can lead to toxic symptoms. Question number 4. Vitamin D deficiency is the reason for rickets, anemia, pellagra, or goiter. What is your option? Yes, it is rickets. The most common cause of rickets is a lack of vitamin D or calcium in a child's diet. Goiter is caused by thyroid dysfunction, anemia, iron deficiency, pellagra, niacin deficiency. So we summarize previous material. And the last question, which mineral is the constituent of the nucleotide? And you have magnesium, potassium, calcium, and phosphorus. Moment to think. Correct option is phosphorus. It's a major constituent of the genetic material, DNA and RNA, and informs the backbone with ribose sugar in them. Potassium is very important in the human body, and it's important for normal growth and for building muscle. And please remember that your body has 90% of calcium to keep for bones, teeth strong, and also skeletal structure and functions. The rest of the calcium in your body plays key roles in cell signaling, blood clotting, muscle contraction, and nerve function. So, calcium and potassium are basic components which play a very important role in organism and in function of different organs. We finished our second part about rickets, summarizing practical questions. And the last part of our lecture is hypervitaminosis D. It's a clinical condition characterized by severe hypercalcemia that may persist for a prolonged time, leading to serious health consequences. Symptoms develop after 1 to 3 months of large intakes of vitamin D. Discontinued excessive intake, renal damage, and metastatic calcification occur. When we discuss with you rickets, I focus information that if you prescribe high doses of vitamin D, you have to follow up a patient in dynamic every 2-4 weeks and to perform blood samples to control levels of basic microelements every 30 days. There are 3 hypotheses to explain hypervitaminosis of vitamin D. First one is toxicity that may be aided by increased serum concentration of the active hormonal form 1.25 hydroxycalciferol, which leads to its increased intracellular concentration. That hypothesis is not strongly supported. Another one is 0.25 hydroxycalciferol has a low affinity for vitamin D binding protein and a high affinity, making it an important ligand with access to the transcriptional signal transduction machinery. In hypervitaminosis D, the concentration of various vitamin D metabolites, especially 25 hydroxycalciferol, are markedly increased, and that is why has strongly affinity. So particular metabolite and its high serum concentration stimulates transcription by itself. And the third hypothesis that vitamin D intake raises the concentration of vitamin D itself and increases concentration of many other vitamin D metabolites. The clinical manifestation of hypervitaminosis of vitamin D are varied but are related primarily to hypercalcemia. The patient can develop fatigue, loss of appetite, weight loss, excessive thirst, excessive urination, dehydration, constipation, irritability, nervousness, ringing in the ear, muscle weakness, nausea, vomiting, dizziness, also can present high blood pressure and heart arrhythmias. In diagnostic measurement is prescribed blood test to check vitamin D levels, calcium and phosphorus concentration in the serum. It is very important to determine if kidney damage is present. Urine test to check for excessive amounts of calcium in the urine, and bone X-rays to determine if there is significant bone loss. In treatment plan is recommended discontinuation of vitamin D supplementation and the reduction of dietary calcium intake. To reduce the amount of calcium in diet, it will be temporarily, and monitor vitamin D level frequently until they return to normal level. The administration of isotonic sodium chloride solution to correct dehydration and restore kidney function is recommended. Loop diuretics can be added once the volume is restored and maintained. In case of prolonged sodium chloride and loop diuretic therapy, relapsing lost sodium, potassium, and chloride is very important. Therapy with glucocorticosteroids will decrease plasma calcium levels by reducing intestinal calcium absorption, by decreasing transcellular active transport processes, and increasing urinary excretion of calcium. Antiresorptive therapy with use of calcitonin, bisphosphonates, or both can be useful in severe cases in which hypercalcemia is the result of increased osteoclastic bone resorption due to 1.25 hydroxycalciferol direct action on bone tissue. So all processes in organism have to be in a balance. And if you prescribe any treatment for any moderate to severe symptoms, you have to follow up a patient and to control his laboratory and instrumental data. For today, we finish our lecture. If you have any questions, please contact me right on my email. I wish you to be healthy, take care of yourself, and thank you for your attention.